quality of life with muscle disease states that symptoms of muscular dystrophy usually lead to difficulty with physical activity such as walking and everyday functioning, lowering quality of life and putting a strain on both persons and their families. The progressive loss of strength and function associated with muscular dystrophy, research to date focused on only physical aspect of individual lives, such as respiratory function and muscle strength. A qualitative study on experience of people who require prosthesis and orthosis states that prosthetic and orthotic device users are experiencing being enablers of social inclusion, improved life situation, greater sense of self-worth, and improved functional performance. So this study was conducted to identify the influence of orthotic devices on Duchenne muscular dystrophy children quality of life in the domains of physical, psychological, social, and environment at Mobility India, Bangalore. So my methodology is targeted population is muscular dystrophy children in Mobility India and community-based and institution-based rehabilitation centers in Bangalore. I have collected the background factors like basic patient informations like age, gender, education, type of residency, type of mobility assistive devices, and muscular dystrophy. So the samples were selected using the convenient sampling. In the total number of 20 samples. So there is a two group. One is orthotic user and the non-orthotic user, which has 10 samples each. 10 samples each. So my inclusion criteria are children with Duchenne muscular dystrophy using orthosis for more than 3 months and non-orthotic user affected with DMD, children aged between 8 to 18 years. Exclusive criteria are severe cognitive disability, children with multiple disabilities, severe mental disorder. So my methodology in data collection, informed consent was obtained from the muscular dystrophy children and their parents. Confidentiality of shared information was assured. The interview was conducted for group A and B, who are orthotic and non-orthotic device users. The quality of life was assessed by the interview method, which took 30 minutes for each person. So outcome measures are quality of life, which is divided into four domains: physical, psychological, social relationship, and environment. So then the data analysis were done using the SPSS software and the Excel sheet. So then the result in group A, which is orthotic device user, mean age was 13.8, age range between the 9 to 18. So type of residency ratio is 70% are from rural area, 30% are from urban, and gender 100% are male and 0% are female. Type of mobility assistive devices are 70% are using bilateral AFO and 10% are knee gaiter, 10% are articulated AFO. Then group B, non-orthotic device user, mean age is 11.9, age range between 8 to 17 years. Type of residency ratio is 80% are from urban and 20% are from rural. Gender ratio is 90% are male, 10% are female. So first we have collected both the group quality of life data using the World Health Organization brief questionnaire, which contains 26 questions. So we have collected both the group data, and we took the mean, and using the t-test we compared both the group mean. So which shows that both the group has a difference but only the psychological domain has significant difference between the user and the non-user. So the alternative hypothesis was rejected and the null was accepted. That actually this result shows that no significant difference between the user and the non-user overall quality of life. But when we compare with the subdomains, which is physical health, psychological, social relationship, and environment, In the psychological domain, there is a significant difference we have found there. So in this discussion, previous studies have stated that the children affected with muscular dystrophy have negatively influencing the quality of life in all the domains like physical, psychological, social, and environment. Another study states that orthotic devices provided participants had a greater sense of self-worth and empowerment as well as improved functional performance. So the orthotic devices not only have the impact on physical domain, but have impact on other domains of quality of life. Thus, this study was conducted to identify the influence of orthotic devices on subjects' quality of life with non-users of the same. So this study shows that there is no significant difference in the quality of life between the user and the non-user. But when comparing the subdomains, only the psychological domain has a significant, moderate significance difference between the user and the non-user. So, so the orthotic device has positive impact on psychological domain. Conclusion: this study encountered the difference between the user and the non-users of orthotic device in terms of quality of life, but there is no significant difference has been found except the psychological domain. As this study has conducted with the limited number of samples, further studies needed with a high number of samples with a larger population that may bring more clarity about the influence of orthotic devices in terms of quality of life. These are my references. Thank you.
Thank you, Mr. Karthik Rajan. From the audience side, anyone have any questions? Please ask. From online audience, is there any questions? Mr. Satyam, Ms. Rai.
Okay. Are you getting my voice?
Yes, sir.
Hello.
Yes, sir.
Nice presentation. Congratulations for your comparative study.
Thank you, sir.
My question is what are the other parameters of quality of life you think that it should be get focused or it should be covered in your study? Means 4 dimensions, 4 domains you have taken: physical, psychological, social, and environmental.
Yes, sir.
Any other you think which has a role or has an importance in your study regarding the quality of life for the orthotic users?
First of all, thank you, sir, for your question. WHO, it states that health-related quality of life includes physical, social, environmental, and psychological.
Yeah.
And these are the 4 main domains which contains everything included in this 4 domains. Even the 26 questions which are available in the questionnaire, each question has related to some activities or some related to some
Related to activity, you have given some
Yes.
scoring pattern.
Yes, sir.
according to the satisfaction level and according to the other parameters in which environment the user is residing or user is using it. You know,
Yes,
that's
sir.
these are all the motivational factors which covered under the psychological aspects.
Yes, sir.
And your study shows that the psychological impacts are very much beneficial in the users who are using this orthosis. No, I agree. Are you
Yes, sir.
agree with me? That's why. Is there any point which you consider which is lacking beside this
Sir,
all 4 domains?
type of residency and income, these all can influence the quality
That
of
comes
life.
under the economical aspect. That's why you have taken the residential areas. Okay, thank you.
Thank you, sir.
Okay, all the best.
Thank you, Dr. Satyam, sir. From any other audience? Thank you, Karthik, for your valuable presentation.
Thank you, Mr. Mrityunjay, for chairing the session.
Thank you, sir.
And joined. So now we have one more international speaker connected with us. Okay, so now we have one more speaker connected with us, Mr. Yatiraj Nirola. He's a prosthetist and orthotist by profession. He has been working with Handicap International Nepal program for over 7 years and has an extensive experience of working more than 10 years in the field of Nepal, currently working as senior prosthetist and orthotist, capacity building. He is mainly responsible for planning, implementing, monitoring, and supervising the activities related to assistive products and technologies from Handicap International and its partner organizations. So please welcome Mr. Yatiraj.
Hello, am I audible?
So he is also a Mobility India graduate alumni. So he will be a supermost senior. So over to you, sir.
Hello, am I audible?
Yes, you're audible.
Thank you very much for the warm welcome, and it's a great pleasure for me to be here, though virtually, and present among among everybody out there, and it's a wonderful opportunity. I'd like to thank you, Mobility India, Ritu ma'am, and everyone out there, and thank you very much for allowing me to present my experiences. And here I would like to share my screen. Can I share my screen?
Okay, so our technical team will make you the co-host. So in few minutes, few seconds. So
yeah, sure.
Yes. Now you will be able to share the screen.
Okay. First of all, I would like to wish everyone for the first International Prosthetics and Orthotics Day. It's a very, very great day for us, all of us professionals working in the field of rehabilitation and in prosthetics and orthotics. Here today, I'm going to present on the role of prosthetist and orthotist in rehabilitation. So, rehabilitation, if we see the whole picture, rehabilitation is a sets of interventions, and basically it's very much essential to optimize the functions and reduce the disability of an individual who are with health conditions. So definitely among those sets of intervention, prosthetics and orthotics is one of the important sets, and it's an organized profession which deals with the study or the application of prosthetics and prosthesis orthosis in a standardized manner. So in all the pictures, rehabilitation, prosthesis and orthosis plays a major role, and the prosthetics and orthotics is a profession which deals with the application of those prosthesis and orthosis. So looking at the aim of the prosthetics and orthotics, we can see it's very essential first to replace or support of weak body parts, indeed facilitate the healing, and then to improve the functions and to prevent conditions from deteriorating or being worsened. So the ultimate aim is to enable healthy, productive, independent, and dignified lives. So overall, we can see that prosthetics and orthotics makes a person to return back to his original form or to restore the functions that the person has lost or through some kind of a, issues and health conditions. So even in a picture, this is one of the picture of a person who worked in a village, and he has been using the prosthesis while working in the farms and agriculture. So it shows that prosthetics and orthotics, with the application of prosthesis and orthosis, makes the person to live a healthy, productive, independent, and a dignified lives. Similarly, to restore the lost function, which let us see the whole picture here. So there will be an application of prosthesis and orthosis to improve the restore the lost function, which ultimately goes to the improving the outcomes. And finally, the person will be achieving the independence, participation, and the inclusion within their own environment where they are interacting on the day-to-day basis. So if you see a beautiful smile of a girl over here, she is able to actually live in a very, very we can say the complex geographical terrain of Nepal. And with the help of a prosthesis, she is able to go to school, get to go for work, and even she can do uphill and downhills. And though challenging, but she's we can say that she's independent and included within her environment. So defining a prosthetist, so prosthetist is a professional, indeed a health professional, who deals with the assessment of individuals requiring prosthesis and contribute in the prescription, fabrication, application of prosthesis, and which we see that the prosthesis is an external device which replaces the whole limb or missing segment. So the professionals who entirely deals with the application of prosthesis are the prosthetist. Similarly, while defining orthotist, like prosthetist, orthotist deals with the application of application of orthosis. And orthosis is an external device that support the weakened or paralyzed part of the limb or whole limb. So talking about the qualified professionals in prosthetics and orthotics, we have two categories, like a clinician category and the non-clinician category. And this is the entire framework that has been provided by WHO and ISPO. Like a category has been divided as a clinician, who includes prosthetist and orthotist, and similarly the associate prosthetist and orthotist. The both categories are the clinicians who undergoes formal education. For prosthetist and orthotist, a minimum 4 years of formal education in university at the bachelor level should be undertaken. And then especially for associate prosthetist or orthotist, a minimum either 3 years of formal education in diploma level or single associate prosthetist or orthotist. As a clinician, they can be accredited. Similarly, for non-clinician, prosthetics and orthotics technician is a category and who must undergo a minimum 1 year of training. So in this way, a whole interdisciplinary professionals categorization has been done in a prosthetics and orthotics. So talking about the role of prosthetist and orthotist, where for the today's presentation, I would like to highlight mostly these 6 areas. Actually, the whole the role of a prosthetist and orthotist underlie keeping the user at the center. Whatever actions, whatever interventions a prosthetist and orthotist would be doing in with respect to the rehabilitation, it would be keeping the users and the family caregiver in the centric position. So based on that, the other roles would be driven. And the first role I would like to highlight here is to be a member of multidisciplinary team or an interdisciplinary team. So prosthetist and orthotist play a vital role to be participate as a responsible member. They have a very, very a significant role in rehabilitation planning. It could be a situation of a multidisciplinary team working in interdisciplinary concept, or a single professionals working through a wider multidisciplinary team approach. Similarly, there is a very, very strong clinical and technical role that leads to the clinical and technical planning of assistive device, especially prosthesis and orthosis, and then the identification of appropriate technology, because we all know that appropriate technology is the one which would empower the persons to use the particular device in their own environment, where they can be easily available and then easily repairable. And then similarly, you can see a picture over here also. A person is working in a very, very rocky, like a garden for him, like the area outside his house, where the person has to adapt this situation. So until and unless person is comfortable based on his scenario and environment, it's very difficult for him to adapt on these devices. And similarly, this is the role where the professional has to, especially they have to think about the evidence-based practices. So the current evidence that is supported by the scientific researches, where the mm, the client or the persons who is going to use is accepting, and similarly the experience of a prosthetist and orthotist would come align, therefore ensuring the evidence-based practices. Similarly, the other role for prosthetist and orthotist goes in the major service delivery mechanism. As per WHO, it has been said that the 8 steps of service delivery has to be followed, which is now has been focused on the 4 steps of service delivery. Basically, the person, the prosthetist and orthotist, has to very strongly assess, find or analyze the findings or clinical conditions where they are going to prescribe the particular devices, which would be very objective oriented for the person to meet the ultimate goal of rehabilitating a person. So the whole contribution to have towards the rehabilitation begins with the assessment and then prescriptions. Simultaneously, based on the prescriptions, a prosthetist orthotist would be fabricating the device following the scientific and the mechanical principles. And similarly, the only fabricating the devices is also not sufficient. It should be, the users should be adapted for the ultimate use of the device, so that they can go back to the environment and utilize it to get the fullest outcome. And none the least, follow-up and maintenance is equally important, which has to be promoted as it's the follow-up and maintenance that the lifespan of the devices would be enhanced, and then the person would be able to use the device up to its maximum utility. So it's very important that the prosthetist and orthotist should focus on a service delivery to ensure the rehabilitation would be optimal. Similarly, the other role where here I want to highlight is on the research and development part. Research and development is a very crucial part, because it is the area which include the innovations. It's the innovations that we can see in today's time, that the outcome of the prosthetics and orthotics intervention has been uplifted, and users are able to receive the maximum output, so that they can adapt on their own environment, so that they can do their occupations. And similarly, prosthetists and orthotists should also be very much keen on the quality enhancement. So it's quality is a very, very progressive process, as various factors are dependent over this. So it's a role of a prosthetist and orthotist to ensure that the service or a device or the whole service planning is on the basis of achieving a quality service or quality provision. Prosthetists and orthotists also play a very important role on the service expansion, especially while growing the service from in the settings because the settings could be various. It could be in a single prosthetics orthotic settings, or it could be a multi disciplinary settings could be and the whole where multidisciplinary team are available. So ultimately the as researchers have said that the multidisciplinary approach or the multidisciplinary team, while working in an interdisciplinary approach, the results for the users are very high. So actually the prosthetist and orthotist should be looking for the expanding their services and ultimately also towards the system development. It's very important the role that the whole prosthetist and orthotist play a vital role in the development of uh, assistive technology service provision in a local settings or in a national setting. So that's plays a various role so that prostate and orthotist can contribute towards the system development where service provision regarding assistive access to assistive devices would be enhanced. The other role here I want to highlight is for the advocacy, because still there is a situation where many people are unaware of the prosthetics and orthotics services, or as a whole the assistive devices services. So while having rehabilitation services in a bigger picture, assistive devices reaching out to the people and improving the access of the people to ensure the reach of the assistive devices, it's very important that prosthetists and orthotists should also be engaged in the promotional activities where they can promote about the role of prosthetics and orthotics, or the role of prosthetists and orthotics in the rehabilitation, generate the awareness among the people and the professionals. And also it is very important to lobby at the national, local, and the government, and even in the global level. We can see there today that the in the awareness, it's very important that if there would be a like awareness generating environment where prosthetists and orthotists would be there, it would be very important that they would be able to highlight the importance of prosthetics and orthotics, what are the quality prosthetics and orthotic devices, how the service delivery should be done, and then what the planning should be done at the local, national level, so that the beneficiaries or the users would be benefited at maximum. So it's advocacy plays a very, very vital role to improve the circumstances and ensure that the governance and the leaderships are aligned towards achieving the objective of ensuring optimum rehabilitation and improving the access of assistive technology. Some role to highlight more also is apart on that the role of prosthetic orthotic even in service delivery is not only limited to the institutional based settings. Prosthetics and orthotists also play a dynamic role to ensure the community based rehabilitation. So there are many people who are not able to access the service from the remote areas to um, the central level. If I just share here the situation of Nepal. Nepal has very limited service providers who are mostly situated in a urban and a semi-urban region. So it's very difficult for the people because the geographical context and due to the limited transportation facilities, high out-of-pocket expenditures, it's very important for those that they are not able to reach to the center. So which creates the high amount of unmet needs on the remote locations to ensure the remote people living in the remote areas are also able to access the service. It's very important that the community-based rehabilitation has to be promoted. And similarly, prosthetists and orthotists should also expand their role to ensure that the service, the prosthetics and orthotic services are available at the community level, where people can easily access uh, for the services. Similarly, the other challenge is the humanitarian crisis. Here I have kept a picture from Syria, and I'm very sure that everybody is aware about the context of Syria. The largest crisis in this decade, if we look at the past. So in such context also, it's very important that the people receives the rehabilitation services. And as we know, assistive technology, prosthetics and orthotics enable the people to reach their optimum functional independence. So definitely in an emergency context, the necessity of the services is also very high. And in those settings also, it's very critical role of a prosthetist and orthotist to contribute for the service delivery, to contribute to make the people to ensure the access of the prosthetic and orthotic services for the people living on those the crisis scenario. And prosthetist and orthotist has also a tremendous role in even in the emergency context. Some a context I would like to highlight here is that a challenging context to the changing context. So if we see a couple of years back, the challenges were still, there are some challenges, but the before challenges we can see that there were very limited awareness on the professional scope. Even the co-professionals, the medical professionals were very much unaware about the professional scope of a prosthetics and orthotics. And just to give an example, for an amputation or keeping the residual length of while conducting an amputation. So without considering the ultimate prosthetic consideration or the prosthetic intervention, it's very difficult to ensure that person after amputation would without considering the prosthetics intervention would attain the ultimate functional independence. So due to those limited awareness, the challenges were very high. So that's the reason sometimes prosthetists and orthotists would be experiencing a situation where the compromising in the prosthetic intervention has to be done. So similarly, the diversity of challenges in the workforce, prosthetics and orthotics are the scarce workforce, especially if I talk about Nepal. As per the ISPO, 5 to 10 clinicians per million population is needed to ensure the service reach to the maximum population. But the current context is that only 22% or 1/5 of the requirement is available. So there's very diverse challenges available in this sector. Similarly, the availability of the quality products and also the service mechanism, because to the ultimate outcome is that till the system or rehabilitation system is ensured at the public health level, it's very difficult to create a very strong service mechanism that reach to all over the country, especially in Nepal, like situations, or we can say that low and middle income country situation. However, if we just look the recent past, the context is being changed, and how those context is being changed, that has been done by very extensive advocacies, promotions done through the various global actors in prosthetics and orthotics. We can take the example of WHO and ISPO as well. And similarly, researches and innovations and the advancement in the science and technology, especially prosthetics and orthotics products, has also changed the context so that people can attain the ultimate the outcome as expected, and then similarly the wider awareness has also been created, which is opening the multiple avenues for the prosthetics and orthotics sector. And I have pasted a few standards and strategic documents that is guiding especially low and middle income countries and countries like Nepal. So in the left too, you can see that the standards for prosthetics and orthotics, and then the very recent global report on assistive technology. So these all will be possible through the diverse role played by the global actors in prosthetics and orthotics. Similarly, Nepal is progressing towards the path that has been shown through the global actors, and Nepal is also able to develop some documents like priority assisted product list of Nepal. And very happy to say that Nepal is the second country to develop this document after the document from the WHO. And similarly, a small project-based document which includes mobility assisted product service catalog. So these are the documents that has been possible, which are guiding the service providers, which are guiding even helping the service providers to generate the advocacy at the local level. So these all things are being possible through the diverse role that has been played by a prosthetist and orthotist, or a team where the prosthetists and orthotists are also a contributor. So my final message is prosthetics and orthotics is a very unique service. It's a unique contribution to ensure the universal health coverage, and also to ensure the health outcome for the people in need of prosthetics and orthotics, or a people, and also it's a profession that is a very embedded in a rehabilitation framework where prosthetists and orthotists are a very specialized part of a rehabilitation workforce. So one thing where I strongly believe is that without prosthetists and orthotists, the whole rehabilitation team is incomplete, because the rehabilitation goal, without considering from the lens of assistive devices for the person with physical impairment and the loss of function, always would remain lacking. So hence as a conclusive point, it's very important that role of prosthetists and orthotists not only lies only on a clinical settings or only on a small workshop or a piano unit, but it is very, very expanded way of a expanded role is there, and everybody has to be aware of this role, especially a prosthetist and orthotist should be focusing to generate to expand their role. Thank you.
Thank you, Mr. Etiraz, for the valuable presentation, informative presentation. Any questions from here? Any question, any concern? So we have one question from online participant.
Yes.
Yes, sir.
Nice presentation. Congratulations, Mr. Yeti. My suggestions, since you have done the advocacy presented in a very, very better way to learn a lot of new things. Since at present we are facing whole world is facing the Russia-Ukraine war, and it has provided a lot of opportunity for prosthetists and orthotist professionals. ICRC is involving them. You have taken the pictures of Syria, humanitarian crisis role during the Syria earthquakes. Nepal is lying under the earthquakes prone areas. Role of rehabilitation professionals is very much required and needed at these times when the natural calamities occurs. And these are in the Russia-Ukraine war, a lot of amputations, a lot of other factors are also involved. My suggestion, is there any study which advocates our role in completing the Millennium Development Goals, whichever has been decided by the United Nations? Or we are lacking in that aspect, or we are complementing in that aspect to achieve the Millennium Development Goals?
I think we are, yes, we are towards achieving those goals because globally we are acting in a different settings. And
Yeah.
thank you very much, sir, that you have highlighted the earthquake of Nepal. And indeed, there was a significant interventions from the prosthetics and orthotics side while responding to the earthquake response. And definitely there are the contribution of prosthetics and orthotics in such settings are also very crucial. And definitely Russia and Ukraine war is a very peak at this moment. And very recently it has been also that the prosthetics and orthotist role has been deployed in Russia and Ukraine. And happy to say that even HI is also intervening as a from prosthetics and orthotics side in Russia and Ukraine. So
Yeah.
I genuinely feel that we are towards the achieving the goals of ensuring the access of assistive products in a global level. So though slow, but yes, we are very progressive.
Yes, also I have studied a report that the polio cases has seen come back in the United States of America, which globally we have declared that there is no polio cases. We have eradicated the polio. That's why means our importance is very much necessitated, and it should be promoted like by organizing these events. And for in that direction, I think ISPO has taken the great initiative that we are going to celebrate, and we are we are meeting on this platform for the celebration of the first International Day of Prosthetist and Orthotist. Thank you. Thank you.
Thank you so much, sir.
Thank you very much. We have one more question.
Hi, Eti. This is Vanilla. Can you see?
Yes, ma'am. Hello.
Happy to see you. And just my question, as you were talking about this Syria and the crisis situations, the role of multidisciplinary team, just what is your experience on the role of multidisciplinary team in that crisis situations? If you have, could you share?
Till now, I don't have direct role in the humanitarian crisis apart from the post-earthquake situations because I have not been deployed. But yes, definitely HI has been intervening since a long time in the Syrian crisis, and the support has been provided. So directly, I do not have any experience on that side, but the information as the emergency context, we have seen, I have experienced here in Nepal in a Maoist insurgency. So long back in Nepal, there was a Maoist insurgency, and there was a situation of emergency as well here, not as intensive as Syria, but there was there.
Okay, thank you, Eti.
Okay, thank you, Mr. Yatiraz, for the informative presentation. And also in your presentation, you have shared a take-home message, like a rehabilitation team is incomplete without a prosthetist or orthotist. So with this, we will move to the next presentation.
Thank you so much.
Thank you. So our next presenter, Miss Helen Cochran. She is the chairperson in ISPO Education Committee, and she is the director of Masters of Science in Prosthetics and Orthotics program. She has clinical experience in both prosthetics and orthotics, as well as international development, working in schools in Cambodia, Sri Lanka, and Philippines. Apart from that, she is active in range of national and international efforts to improve quality and access to appropriate prosthetics and orthotic services. So please welcome Ms. Helen.
Good morning, everybody. Thank you for inviting me. I can't believe what a great job you guys have already done in getting this up and running so quickly. I'm going to share my screen and I'm going to put my presentation up. And hopefully, can everyone see the presentation screen?
Yes, yes, ma'am.
Perfect. All right, so I got a really nice introduction there. Thank you very much. I'm going to thank you all for welcoming me back to India. In fact, I didn't get to come there this time. The food isn't as good here, but I'm really happy to be invited. I'm coming today to talk to you about education standards, and I've been involved with ISPO for many, many years in this same kind of work, working with their standards committee as well as on the education committee. And I just want to clarify a little bit of where we sit under the ISPO structure. There is actually a continuous professional development section that falls under some of the other committees. But we're the education committee that talks really about how we learn about prosthetics and orthotics and why it's so important. So I'm going to talk a little bit today about where we are right now in the world with our learning about education. I'm going to talk about what education standards are and what they're not, a little bit about the history and how we've gotten to where we are, as well as some of the trends affecting education, and finally, how far we've come in such a short amount of time, really, as a profession. ISPO standards are voluntary. They're a voluntary process of quality assurance. They are an objective external audit to ensure programs meet a minimum standard. I think to date, Mobility India is the only school in India that has currently undergone this process. But I know that I've met Ritu many, many years ago. One of the first people I met in international development when she was an auditor for the school in Sri Lanka. So we go way, way back. Our standards are now endorsed by the World Health Organization. The World Health Organization used to be the implementer of those standards, but now ISPO owns that and WHO endorses us. What I will say is that they are not legislative and they do not infer reciprocity, which means no country, no employer is bound to necessarily to recognize it, but we see more and more that as a transparent standard, they're being used by employers and governments to help them guide their decision making when they're hiring internationally. These standards have been in development really for a very long time. They started out with scientific discussions in the late 1960s in a number of regions in the world, and eventually evolved by 1992 into the first set of standards. And since that time, we've worked really closely with the schools and we've worked really closely with the World Health Organization in order to be able to help build the capacity of our profession. And I think most of you will know in 2017, the World Health Organization put out its service standards for prosthetics and orthotics, and that was immediately followed by the updated ISPO standards. So what I'm going to talk a little bit here is some updates that may or may not be super familiar to people. I think most people probably in the room have heard of Category 1, Category 2, and Category 3. These were designed to improve the access to care and improve the standard of care by really setting out what the scope of practice and what the competencies were for these various different disciplines, and really trying to get programs to have a uniform standard that would help build a system of sustainable service. Early in the early 2000s, we had a very small number of programs, about 7 programs. They were mostly in less resource settings. And the personnel from those programs were able to establish and provide feedback to other programs and to help to achieve an agreed upon standard. And these programs started to be able to use this for lobbying and communications, as well as program development in their own country and in the world as a whole. Essentially, these programs were able to see that there was strength in numbers. They were aligned and they could collaborate amongst each other. It demonstrated their inclusion in the global community and for professional services. And so the education standards really started to evolve into this very objective evaluation, helping programs to look at themselves and help them to develop, but also allowing them to have an external review that would help them to advocate for resources within their own setting. So whether that was being able to go to the heads of schools or to their government and ask for money, equipment, recognition of their profession, all of those kinds of things. So as the time went on, we started to see that instead of this being trying to strengthen where programs were new and needed sort of that extra support, even in higher income countries and in a much broader range of places, people were actively seeking to become involved in these various different categories. So just by 2008, there were more than 20 recognized programs, and there was a great diversity in the model of those trainings. So I think you see that in India as well, where you have Mobility India that has lots of modular things. There's also university-based programs, and that was true for lots of places. I think India is one of the places with some of the highest number of schools. So you have lots of challenges in working together, but lots of opportunities to share your various models. One of the other things it was able to do was help highlight the fact that most prosthetic and orthotic education actually face similar barriers to greater or lesser degrees. We generally and still have a bit of a lack of data on the needs and the impact for qualified services. And it's probably one of the biggest and most prolific barriers. There was an inability for us to prove the value of our services. And in many places in the world, we started to see encroachment from other professions, and that there was a lot of difficulty in meeting some of the ratios and levels of training that we needed and all of those kinds of things. So that set us on another path, starting to look at how we could evolve the standards to the next stage. So that work actually started in about 2010, where we started to look and see exactly what was going on. And how complex that pathway was. We were able to survey membership of ISPO as well as educators. And there was a lot of really big findings that came out of that. One was that the ISPO categories weren't actually that clear outside of the profession. And even sometimes within the profession, people felt like they knew what was going on. They understood the structure. However, as it turned out, there was not really as much understanding as we thought, which is why we've evolved a few things in terms of the terminology, which I'll talk about a little bit later. We learned that there was definitely a need for upgrade paths, so that we had all these people who had wonderful skills, but maybe didn't have the academic credential, or that somebody started as a technician and had wonderful hand skills, but they didn't really have a way to evolve inside of their profession. And you can see that in Mobility India and its evolution, and from going from single discipline to at one time what was called the full category 2, and now up to that professional level, which I'll talk about in just a minute. We also learned a lot about the challenges of things like the increasing information that was coming at people, and why it became increasingly important that people had some of those skills that are sometimes defined as research, but really are about evidence-based practice, the ability to work through different kinds of information and look at your journal reports or participate in studies or design studies that were really important. So that's why we see that next level appearing. That there were a lot more opportunities for collaboration and continuous professional development. And that around the world, there were lots of places that were evolving their design. During this time, there was also a whole lot of work and interest that was happening. And I'm sure that as of today on International Prosthetics and Orthotics Day, this is a group that will really understand how challenging the environment is for us, and that the unmet need is really profound. That 90% of people who have who need prosthetic orthotic services don't have access to them. And I think I can use India again as a wonderful example of how hard the professionals there have worked to move out into the community and really bring the services to where they need to be. We have a need to, on the basis of the growing population of prosthetic orthotic users, which I think probably lots of people have talked about over the course of the day. We really have, in order to just maintain the status quo, we actually need to double the number of service providers before 2050 in order to just try and meet that need. I've used these examples here of these are the service users in Canada, and this is the projected development of the number of professionals. So we are not alone. It's something that is replicated everywhere in the world. So hopefully people will be enrolling in Mobility India at twice the rate they are now. We also saw that there's a real big strength in regional and international collaborations. The EU did a lot of work in setting up a structure to make transnational frameworks for education. FATO has brought Africa very close together. We work with the Global Educators Meeting so that educators around the world in prosthetics and orthotics can share their knowledge. And there has been lots and lots of different ways that we've tried to work together. I think, again, I'll say Mobility India is probably one of the better examples of diverse pathways, even within an individual program, where they're working with outcome-based education, which means that we understand what it is people need to do, and then set our training objectives and program to meet those objectives. Stacked and ladderized programs, as I mentioned earlier, you maybe start as a technician and work up to an assistant or an associate, and then up to the professional prosthetist orthotist level. And there are so many other ways that we're able to do that. So all of this work has evolved over many, many years, and through the great collaboration and support of all different kinds of professionals around the world. And so from the early 2000s, when we had about 7 programs, we are now represented. ISPO accredited programs exist in 28 countries. There's 48 programs under that, which is, some places have a very holistic approach. They have a comprehensive terminal competency exam where the students from every school participate in the same exam, and they are recognized under a pathway. And we have about 65,000 ISPO recognized graduates around the world. So that's pretty exciting growth in just about 20 years. And I said I would talk a little bit about this new terminology. I'm going to say, although it doesn't feel so new to me, it's still not very well embedded in the common vernacular, as they might say. We at ISPO, and you'll see this terminology also reflected in the WHO standards, that we now describe the occupational groupings as a prosthetist orthotist, an associate prosthetist orthotist, and a prosthetic orthotic technician. So hopefully everyone knows a prosthetic orthotic technician is someone who's trained at the level aimed at technical design and fabrication without providing clinical intervention. The associate level prosthetist orthotist is someone who is the practitioner aimed at general clinical service delivery. These are the people who are very often on the front line and seeing a high volume of patients all day, every day. They may also do fabrication and some of the other aspects. And then the prosthetist orthotist level. So this is the level that we're trying to aim at the breadth of clinical service. So it's intended that this group would have the capacity to be leaders in the field, advance the educational or service models, or how we actually deliver that. And we chose this terminology of prosthetist orthotist associate and prosthetic orthotic technician. You'll also hear people say at the professional level, and that was to align with the International Labor Organization's terminology and how they classify every job everywhere around the world. So we describe the prosthetist orthotist as the professional level provider, and the associate prosthetist is the associate professional level, and technicians as technicians and other healthcare providers. And hopefully these terminologies really help other professions to understand what capacity they should expect, and how, I've been many places in the world where everyone who makes artificial limbs or braces is considered is described as a technician. So we like to be really careful with our words and try and help this become really well embedded so that other professions understand who we are. The model of this is almost in many countries, it's an undergraduate to a postgraduate. So it means it's a bachelor's degree or maybe a master's degree. It really requires a lot of practical experience. In many places, there is an internship or an externship. So they stay in a clinic within the school, and they practice, or they go out into a healthcare setting, but they're supervised, and then eventually come to the experiential piece of things. There are a range of entry and exit points. So I hear people talk all the time. In the old standards, we talked a lot about the amount of time needed to be spent on various sections. And people try to kind of compare apples to oranges. So you might say in the United States, the prosthetist orthotist training pathway is only 2 years. Because the school is a master's degree and it's for 2 years, but they also have 4 years of a bachelor's degree ahead of that. And then they have 2 years usually of residency. So actually that pathway is about 8 years. In other places, like the UK, the entry to practice might be 4 years. They do that in a 4-year bachelor's degree and then go out into the profession. So this is the area that probably is most variable, because graduates are expected to have a much broader range of responsibilities and to be able to continue to learn independently after they graduate, and really be the people who are directing things like continuous professional development and to become faculty in schools, those kinds of skills and things. And then we have the associate prosthetist orthotist level, which is the training level that happens again in a range of settings. It happens through colleges and vocational schools, private institutions. Again, it can be modular, so it can be shorter or longer. And I feel like this is an area that is that actually, the original group where the profession was really being evolved from started really to kind of help this group become embedded. We now start to see the UK, the United States, and lots of other places actually bringing this this part of the profession into the limelight, because it really helps to build a service where we can start to actually meet the volume without people having done 8 years. That it's an efficiency of service that actually really improves the quality of service for the users, because you have people who are real specialist experts in that direct clinical care. So I expect that we'll see it evolve more and more as the years go on. I'm sure Ritu will be very tired at the end of all this, with all the jobs she has at the end, just to double her enrollment. The other thing, prosthetic orthotic technicians. This is an area where, again, different places in the world do it differently. In some places in the world, people come in and they learn from someone who is an experienced technician, and they spend years building that craft. In other places, like Canada, we actually have multiple pathways. In Canada, we have a 2-year training program, and then you do a 2-year residency before you're considered to be a registered technician. But this is a place also where roles and responsibilities are really growing. This is really considered an essential element of service for things to be effective, and for clinicians in the prosthetist, orthotist, and associate level to have really good technicians who can be trusted to take responsibilities to build devices and do things safely. This is a really important way to optimize and make the service efficient. So we always want to make sure we're helping to promote that group. And we've had subcommittees for this level. We've built them into the accreditation committee, and we're hoping that we'll be able to help this group evolve much, much further along. So how do we know that this structure works? And again, I'm going to flag up Mobility India. Mobility India was one of the schools that received grant funding from USAID or sponsored students from the USAID over many, many years. And we went back and did an impact assessment to look at not just Mobility India graduates, but graduates in about 13 different settings that were all programs that were beneficiaries of these funds, to see whether or not this large scale donation by USAID had really made a big impact. And we learned a lot of really wonderful things. We learned that prosthetist, orthotists, and associate level professionals both provide very good clinical service, that the prosthetist, orthotists, as expected, were more likely to engage in senior roles like education, mentoring, and complex case management. And that the methods of training and education, traditional versus blended, did not significantly impact the quality of device, so that there was lots of ways that we could deliver education and get a really good outcome. So that's pretty exciting as an educator, to be able to know that you can do what you need to do and move on. So as I mentioned earlier, in the good old days, we talked a lot about the amount of time people needed to spend in things, but that really depends on what the point of entry is, and lots of other things. So we restructured the standards to encourage a stacked or a ladderized approach. So you can see here, the blue line is the line that is the standard, and how what outcomes we would expect graduates to have. And in most of these areas, it shows you what the P&O technician needs to know under this standard, what the associate would need to know, and then what the professional would need to know. And those things range depending on the section very differently. Some things everybody's got to know it, and other things there's just about having some awareness. They're still considered the minimum standard for entry to practice. So in some cases, we do definitely see that programs actually, it's more likely actually that the programs exceed the minimum expectations in many standards. And in some places they need strengthening, which is why it's important for us to keep coming back and working with schools to help them develop. The institutional settings are really the same regardless of the level of training or the setting. So by the institutional standards, that's really about recognition of the profession, the physical plant, safety, all those kinds of things. But I say in terms of what the graduates need to know, those things are stacked so that we can build upon. So you could have a standalone program, or you may be able to build. So you started out as a technician, you got your associate level qualification, and then you worked for a couple of years and came back to become the prosthetist orthotist by building in some of those other attributes. And hopefully this will help really build the profession and allow people who are really skilled to move on with their with their lives. So I'll talk a little bit about some of the things that, what I'll say is probably one of the biggest adds that we've placed into the standard, which is the positioning mobility devices were added to core content. So we'd always sort of suggested that maybe wheelchairs, standing frames, those were things that should be part of it. But we really moved these over into the area of a core competencies. because essentially we recognized through work with various stakeholders that wheelchairs and prosthetics and orthotics are clinically and technically linked service. They are intrinsically linked. The people that we see often use both of these mobility devices, and the devices that we use impact the individuals. So you can see how the prosthetic user, that's Senator Tammy Duckworthy in the United States, who's a bilateral amputee using a wheelchair, and how her feet are positioned here, which is fine for her. She's obviously strong enough. She can hold a baby on her knee. But we know that this orthotist who's putting a brace on needs to be very careful in how he's positioning the footrest back for this patient. Or, for example, this young woman who's wearing a spinal brace and how that interacts with the fitting of her chair and her postural support. So we know that we need, as orthotists and prosthetists, really need to be aware of this and need to have at least basic competencies. We also, in recognition of the challenge of setting up various different workshops and training people for different things, that prosthetic and orthotic occupations are actually uniquely positioned with knowledge and skills that are directly transferable into wheelchairs. And we very often have tools and equipment within our setting that will allow for us to be really good at delivering service comprehensively, that somebody can be seen in for one or more devices within a single setting. So we hope to encourage that. And a little bit of a plug, perhaps, that ISWP, the International Society for Wheelchair Professionals, is actually making this really easy. They have free online training. You need to do the hands-on training to acquire a certificate. And those are arranged around the world in a lot of different ways, but the training is online. It is free. It's in English, French, and Spanish. They're also in the process of developing a website that is aimed at advocacy and education and training. And that should be released very soon, which has a lot of wonderful resources available for you if this is something you're interested in engaging in. And that established training package is actually available for free off the ISWP website. You can use that QR code to get in there if you would like. And my summary is that there is an increasing gap between needs and resources. We should be working and growing collaboratively together and continuing to encourage those diverse education models and making sure we have that skill mix that is really important to optimizing outcomes. So I am happy to take any questions. Here are my references for the talk today. And if anyone isn't familiar with it, there is a free atlas of spine orthotics available on the internet. This was supported by ISPO, and it's free to you. It's a wonderful book. I'm going to stop sharing so I can see everybody in the room. I think if I can get out of my presentation here, and I see that there's 2 things in the chat, but I don't know what they are yet. So I'll ask away. Let me see. Okay, so that was we've got a hand up there. Yes.
Yes. Hello.
Hi. Is that Satyavan?
Yeah, good afternoon, ma'am.
Good afternoon.
Nice to see you after the Global Educator Meets.
Yes, good to see you again.
Yes, I have attended that. It was a nice program, and once again, I feel very much lucky that I have got your voice and gone through your slides. My question is, there is no question, my suggestion. We have to start. You have focused that ISPO has recently created a subcommittee for P&O technicians. We need this. These are because if the good craftsman is there, it will be very helpful for all of us to provide our services to the not reachable, to the unreached persons. With the educates your data also, 90% of world population needs are not getting our services. For that direction,
Yeah, and I think the WHO service standards are actually a great resource for that, because they highlight very clearly that for the service to be the most efficient, that every clinician should be supported by one non-clinician. So every associate and every prosthetist orthotist in WHO's estimation should have a technician, one or two technicians, or a technician and a support staff, so somebody doing the administration, so that people who are really experts in what they do can focus on that, and they can hand over things that can be done at a higher volume or a quicker rate by allowing people to just focus on either the fabrication or the administration. That it's not, I think we see it a lot because we're a small profession and there's not nearly enough of us, where we have maybe we have two associates working in a clinic, and they're doing the billing and they're checking in patients and they're making the devices, and they could see many, many more patients if they had someone supporting them in that non-clinical background, the non-clinical side of things. So I would really encourage it, and for people to think about that in terms of increasing access, that the skill mix and the structure, we can train technicians at a rate, probably 50% faster, because they can focus just on the fabrication. They don't have to take in all those clinical aspects as well. And if we have really good communication and technicians are really properly trained, they can articulate things in a way between the professions where you're no longer becoming this associate who now also needs to instruct and teach someone to fabricate as well. So yeah, I would strongly encourage that.
And one more thing, in the morning session, we have we are lucky that we have got to listen to the speech of Dr. Sanjay Sharma, who is a pedo orthotist. And I will suggest ESCO to start the specialized courses for prosthetics and orthotics professionals, which includes the other aspects also, because it is the need of the time. Because it is the need of the time that we have to specialize in our focus areas.
Yeah.
Whether it is multidisciplinary approach, it is needed. It is the need of the time.
Yeah, and it's prosthetists and orthotists are actually a wonderful thread throughout a healthcare service, because we treat people everything from acute care to lifelong service in the community. So we're a really important point of articulation, and that's why multidisciplinary care is so important, and why the education piece, so that you can communicate with other professionals in the same language, for example, is so important. So yeah, agreed. Zia, I see your hand is up.
Hello, madam. How are you? Zia from Pakistan.
Nice to see you.
Madam, it was excellent presentations. I have a question. Maybe it's not related to this presentation, but since you are a chair of ISPO Education Committee, I just want to know about the students teacher ratio in a P&O school. What would be the ideal student teacher ratio? Like, for how many students we need to teach, how many teachers?
Yeah, so I will say that the long answer is that it really depends on the model of training and how things are working out. Statistically, it's been a long time now. There was a study mostly out of European schools, and it's a trend that I think really kind of holds across a lot of places, but it's usually about a 1-to-10 ratio. So one faculty member for every 10 students is common. However, we see much higher and much lower ratios in different places. So you might see a school that has a very high volume of students and maybe doesn't have as many faculty, but then they actually have those students, for example, go out into a residency. So they do this in-class piece that is the ratio is lots of students, small number of faculty, but then they get a lot of experience with like a one-on-one mentor, right? So you really need to make sure that you're being safe in your environment. It's one of those things where, we have physio classes here in the United States. I'm working at the University of Pittsburgh, and they have 60 students in the class.
Yes,
but nothing bad is going to happen if a physio, like if they're in a room and practicing a skill, it's not dangerous. But if we're in a room and, sometimes we have 3 faculty members for 12 students, because we've got a faculty member in the clinic space with the volunteer patients. We've got somebody else who's in the machine room and somebody else who's helping with molding or heating or something along those lines. So you really have to, you know, your overall number, I would be targeting that kind of 1 in 10, but really setting that for the learning activity that they're involved in. And, you know, and to say, sometimes I'm in a class and all we're doing is range of motion. I can have 12 students in there. I'm by myself. I don't worry about it. I know schools that'll have 24 students doing that, but really you have to be very clear about what it is, you know, evaluating the risk and the learning activity that you're doing, because that is one of the things that makes us more complicated than anyone else.
Okay, thank you.
Yes.
And one more question is regarding this piano technician. What is the minimum qualification required to become a piano technician? And do we have any model of piano that the piano technician, they're already accredited by ISPO? Any
So, yep.
school?
So right now, the Cambodian school is the first school to have a technical program. I believe the program is not much more. It's about a year, maybe a little more. The way at the time that we were building the new standards, we really tried to look at transnational frameworks. So we looked at frameworks that were saying, somewhere where they had to compare between different countries. And so we looked at all the ASEAN. We eventually settled on using the frame of reference of the European qualification framework because it was the most established, and a lot of the other frameworks basically worked off the same pattern. They kind of used that as their base. But essentially, we say we think that prosthetist orthotist minimum level EQF 6, so bachelor to master's. The associate level was a level 5, and the technician about a level 4. So that is, you've done high school and you have some specialist training. So it can be a much shorter training pathway. We have a number of schools that exist, but I say only Cambodia right now has gone through the technical training, the technical accreditation process. And so every country calls it something different. That's when I always show that thing, which was how the Irish people overlaid their training onto the EQF. And it's that you have to look, the ILO is another good place to look. We've set that at the major group 3 is where we think technicians should be. The International Labor Organization gives an occupational framework, and it says, you know, at a level 3, these should be the kind of levels of skill. So we want them to be kind of experts in what they do and able to communicate. And, but I say they don't need to have the range of decision making. They don't need to teach other people necessarily, things like that. So, yeah, if you look at the sort of towards the back of the standards handbook, you can see that table, and it will say, for example, we really want to encourage evidence-based practice, but technicians don't need to be researchers, but they do need to know what their role is in research. So you'll see that most of that is applicable only at the level of the prosthetist orthotist. Some things, you know, if we want associates to gather data, there's some attributes that we think that a technician would, or an associate would need. And then the technical level is just, you need to understand what your role is here and why it's important. So those are the kind of.
Thank you very much, madam. Thank you very much.
Thank you. Okay.
Helen, this is Ritu here. And,
Hi, Ritu.
Hi. Just to add what Jia has asked about the ratio, Jia, in Indian context, for master students, for master program, we have 1:6 as per the council guideline. But for a bachelor, there have been a debate whether it should be 1:8 or 1:10. And again, as I agree with Helen, it all depends on learning outcomes, the settings and the systems. So, so I think just for your idea that this is what we are debating on, 1:8 or 1:10.
Thank you, madam. Thank you, Ritu, madam. Thank you very much.
Yeah, and I say really using and try. I think also, you know, I'm all about the data, trying to document why you're doing it, right? So, like in my own school, there are times where there's 3 of us assigned to a class, but I don't go into the workshop every single class. But when they're learning how to use the bandsaw and somebody else is on the Troutman and the others are trying to like start cutting things out here, we have 3 people. One person is standing at the bandsaw, right? So really identifying that where they need to be and when they need to be in the right place, so that you don't have lecturers standing around, not doing anything because there has to be, a 1:10 ratio or whatever it happens to be. Satyavan, you have another question?
Yeah, one more thing, that we have to focus on research also, patent research.
Yeah.
That's I have advocated in the Global Educators Meet also, and once again, you have presented your. I think innovative ideas are there, but
Yeah.
someone takes the copy it and publish it by their name. That is also very dangerous for all of us.
Yeah.
In that
And
direction, we have to. Yes.
Sorry. Yeah, I'll also put in a plug. For those of you who were at the Global Educators meeting, you were in focus groups about research
Yes.
around P&O education, because research across the board is absolutely urgent in our profession. We're decades behind other professionals, but there is about to be a survey coming out to educators, share it to all of your faculty, to ask about priorities in research for education in P&O. So I think in the next week, you'll see that come through, and the idea is to get feedback from as many faculty members as possible. So I'll put my plug in there.
Okay, thank you very much. We have one more question.
Sure.
Yeah, hi Helen, this is Vanilla from the audience.
Hi there.
Yeah, Mike, I have two questions. The first one is, as in India, I think it's the Mobility India which is having the Cat1 recognition, so that's right. But the next level, if the same has to be integrated into the national curricula or into the National Education Council body, so that the benefit goes to the overall country, or is there any role of ISPO taking into the national educational body?
So I think there are different times where, so for ISPO, when we come in to do different things, we will often meet with government or different representatives and try to advocate for that. I say, we're not legislative, we can't force them. However, what you do have right now is the World Health Organization. Those standards were actually developed in lockstep, right? So we were working on the education standards, they were working on the service standards. So those terminologies, the standard of reference for WHO, like in the book, it says, here's an example of what you should be doing. So you could actually take the World Health Organization standard and the ISPO education standard and meet with government and talk with them, saying, this is the framework that the rest of the world is using, that WHO is endorsing, and it's telling us a lot about what we need to be doing or should be aiming for within our own profession. And I think you have those two things are very, very strong in the documentation. I was not involved with any of those discussions. I know that it's very, very complicated in India because you have so many schools and so many different ways of doing things. But I think you're standing on very solid foundation if you can pull up documents that are globally recognized, and you can say, almost 50 programs or 30 other countries are working with these standards. Why are we not working with those standards? Or how can we integrate these in some way? It's always a careful negotiation, I think.
Okay, thank you.
Sure.
And one more question. When you were talking on the different types of programs, you were also mentioning about the outcome-based education,
Yes.
SACT programs, just to understand the difference between these two.
Okay, so stacked programs are how the programs work together. So for example, you might have stacked or ladderized is another way that it's been described, is basically that the training model is set up so that you can take in 30 students as a technical training program, and you could train 30 students, and then the ones with the highest marks, the ones that are most interested, could then take another level of training that this qualifies them for entry to the next level, so that they're whatever, for example, they get a diploma as a technician, then it feeds into, they're eligible to go into this bachelor's degree where they get an associate, and then they go on to the next level and they become a professional prosthetist orthotist at the master's level, and they're learning research. And you go from 30 students, for example, I mean, you can have everybody go all the way up, but the most effective way for that to be is get people with good hand skills or good academic background, and they go up to the next level. And maybe you have 30 here and 20 here and 10 here, so that you've got this efficiency. That's the ladderized or stacked programming, is how those programs work together to evolve. And the outcome-based education, you will hear competency-based and outcome-based, and they seem to be, I'm not sure that they're, you know, the textbook is that they're interchangeable, but they're often used interchangeably, where essentially outcome-based is where you look at what the attributes are at the end. So we're giving you the list of where those standards, the attributes that graduates should demonstrate. It's standard 1. It's describing what we think a graduate should look like. And then you work backwards for that and do constructive alignment. You say, I want to teach this, I'm going to do it in this class, I'm going to use this learning activity, so that you're worried about what the outcome is, rather than, you know, how many hours you're in the classroom, or some of the other things that are not, that we've always done is, you know, we need to be in school for 4 years and then we will be competent, right? I wish that was how it works, but I mean, we've had consultations with university programs. They come out with a bachelor's degree. They've been in the school for 4 years. They have wonderful faculty. Everything is great. And the students read all about prosthetics and orthotics. They never make a leg. And those programs, no matter how much time they spend, those students aren't competent. So if we say at the end, we want them to make, be able to make this leg or assess this thing, then we need to build the program that works that way. And the example I'll use is we take in students from bioengineering all the time. They have a 4-year degree. They come in and we focus very much on clinical and hand skills, because I don't need to teach them as much in terms of biomechanics and physics and all of the kind of academic subjects. They come with that, they're ready to go. I just need to focus on the core clinical. So now it's only a 2-year program, but they have 4 years of competency building before they get in. So there's lots and lots of different ways to do it. I think human studies, an example, that they only take in students who have previous experience working in the field. So they have lots of hand skills, but then they bring them in and they give them the academic background and the credential. So there's lots and lots of different ways for people to be able to do this, and lots of ways for it to be effective, as long as we think, like, at the end, whether you came in with a lot of clinical and hand skills because you've been doing it for years in the field and you had your academics overlaid, if we test you at the end, you can do the exact same thing as the group who did a whole bunch of academics and then a whole bunch of clinical, and then they were able to do it. So I would encourage people to think outside the box, to not try. We're very careful actually not to give times or durations, because it's different in every setting. The Philippines, for example, has only 10, when I started there, it's different now. They had 10 years of primary education. So their first 2 years of university was like the last 2 years of high school in other settings. So we had a 5-year program to get a bachelor's degree. So the time isn't so important. It's really the outcome at the end, if that makes sense.
Yeah, thank you. Thank you, Ellen.
Thanks.
Okay, we have one more last question.
Sure.
Miss Kajal.
Hello, ma'am.
Hello.
So I'm Kajal. I'm MPO student from Mobility India. So
Hi.
Master students, ma'am. Master of Prosthetics and Orthotics.
Excellent. I love it.
So as you were discussing about the categories, ma'am, Cat 1, Cat 2, and Cat 3. So as per my understanding, the BPO students, they will come in category 1. So what will be the category for the MPO?
No categories. So the the categories are how we historically named things. So I want to get everybody off the page of using category 1, category 2, category 3. People couldn't really tell whether category 1 was the top or the bottom, and things are really confusing. At the bachelor, at the master's level, where you're applying, you are applying to be a professional prosthetist orthotist. You are at the highest level where we expect you to come out and be a leader in your field, to be able to think about the service model, to contribute to the body of evidence. That's at the top. In terms of, you have to have all the skills. The associate level, that is an associate professional, and that would be what we used to call the category 2 is probably more in that range. But the category inside the profession, we all knew category 1, category 2, category 3, and we didn't. We learned very, very quickly that in fact that wasn't actually true. But yeah, the master's level, that you guys are doing, the expectation there is that you're coming out at the professional level within the occupational structure. So that's the top of the training volume, right? You've got to get all of the attributes under there. Did I answer that question?
Yeah.
Yes, ma'am. Thank you, ma'am.
Helen, just in continuation what Kajal has expressed her basic. Helen, can you hear? This is Ritu here again.
Hi, Ritu.
So the Kajal who has raised her concern that what will be the category for master, and as you said that they will be at the professional and at the prosthetist and orthotist level. So actually the concern what present master students of Mobility India have, who have recently joined in last 2 years, because we have just initiated this program at MI. So bachelor program, we have received the recognition for the prosthetist orthotist level. So now when the new, those who are the Mobility India graduate of a bachelor and joining the master program, they will receive the ISPO prosthetist or orthotist level status. But those who are joining as a fresh Mobility India master students, they have the concern that how they can get. So, so that's what I had told them, that we have to apply separately to ISPO for master program to look at it and then appear for the examinations. Am I correct, Helen?
Yes. So sorry, I didn't understand that timeline there. Yeah, new programs. Usually what happens is around the first graduating class, it may not always be the first graduating class, but Mobility India would apply to us. We would come and evaluate the program and say, assuming you haven't decided to cut a bunch of corners with your master's degree, I wouldn't be super stressed about it. But yeah, it is a process of application. There's never any guarantees, but yeah, the program should be trying to prepare people for the right level of service. Is that the right question?
Okay, thank you, Ms. Allen.
Thank you.
Sharing the information regarding ISPO standards of education, especially in the field of prosthetics and orthotics, and many doubts our students and faculties were having. Now I think you have cleared everyone's doubt.
Excellent, wonderful. Enjoy the rest of the day.
Yeah, and thanks, Helen. Thanks a lot for giving this time. I know it's too late for you. So
too early for me. It's
too early for you.
7 o'clock in the morning.
Thank you, but you look so cheerful, and so thanks a lot for your time.
The hard part's done now.
Yes, you're done. So bye-bye.
Enjoy the day. Bye.
Thank you all the participants.
Thank you.
Thank you all the participants present over here and joining online. So again, tomorrow we will meet 10 o'clock or a little bit early so that we can start the program.
International Piano Day, and we will have some welcome at the entrance and some kind of other activities. And we will also have ISPO President India as a chief guest. So we will meet little early so that we can start on time. As well as ISPO headquarters, right? So Mr. Cloud will be there virtually, and we will start the program on time. Thank you. Thank you. See you all tomorrow.
At what time we have to meet? In the morning? By 9:30 or by 10 a.m.?
Yeah, we will gather maximum by 9:45 so that we can start by 10 o'clock. If there is any technical glitch or any kind of issues, we can sort it out and we can start by 10 o'clock.
Yeah, that will be better. Thank you.